Irritable bowel syndrome is a functional disorder of the gastrointestinal tract characterized by chronic abdominal pain or discomfort with altered bowel habits and whose symptoms cannot be explained by organic, i.e., structural, causes. Irritable bowel syndrome is the most commonly diagnosed gastrointestinal disorder. It is more common in people younger than 50 years of age and between 20 and 30 years of age, and is more common in women than in men. Abdominal pain in IBS is usually described as a cramping sensation of variable intensity with periodic exacerbations. The localization, intensity, and character of pain in IBS can vary. Pain is often associated with defecation. Some patients reported relief after defecation, while others reported the opposite. Your emotional stress and the food you eat can exacerbate the pain. Other complaints in patients with IBS include bloating, food intake symptoms, diarrhea, constipation, alternating diarrhea, and constipation. There is no specific test for this disease yet. Patients who have no alarm findings on history and physical examination, have normal limited laboratory tests, and meet the Rome-4 criteria are diagnosed with IBS. Abdominal pain on average at least 1 day a week for the last 3 months, accompanied by at least 2 parameters. Relationship with defecation. Change in frequency of defecation. Change in stool shape. Complaints must have started at least 6 months ago. Rome-4 criteria for IBS in children. All of following criteria are met for greater than or equal to 2 months before diagnosis. Abdominal pain greater than or equal to 4 days per month with greater than or equal to one of following. Related to defecation. Associated with change in stool frequency. Associated with change in stool form, appearance. IBS subtypes are recognized according to the dominant bowel habit reported by patients at times of abnormal bowel habits. The most common change is from predominant constipation or diarrhea to mixed bowel habits. Patients with alarm symptoms undergo additional evaluation to exclude other features of similar symptoms. Starting age after 50 years. Rectal bleeding or melena. Nocturnal diarrhea. Progressive abdominal pain. Unexplained weight loss. Laboratory abnormalities, iron deficiency anemia, elevated C-reactive protein or fecal calprotectin lactoferrin. Family history of IBD or colorectal cancer. The exact cause of IBS is unknown and its pathophysiology remains unclear. Despite numerous studies, the data are contradictory and no abnormality specific to this disorder has been found. Let's look at some of the factors thought to play a role. Abnormal GI motility. Selective hypersensitization of visceral afferents in the gut. Changes in intestinal and colonic microflora. Bacterial overgrowth in the small intestine. Food allergy, intolerance. Psychosocial factors. IBS is associated with other conditions such as fibromyalgia, chronic fatigue syndrome, also known as systemic exertional intolerance disease, gastroesophageal reflux disease, functional dyspepsia, non-cardiac chest pain, and psychiatric disorders such as major depression, anxiety, and somatization. If there are mild and intermittent symptoms that do not interfere with lifestyle and diet changes are recommended first and foremost. Pharmacologic treatment is recommended for patients who do not respond to initial treatment or have moderate to severe symptoms. Patients with IBS may benefit from the exclusion of gas-producing foods, a diet low in fermentable oligo, D, and monosaccharides and polyols, and, in certain cases, avoiding lactose. Patients with IBS should be advised to exclude foods that increase bloating, alcohol, and caffeine. Patients with known lactose intolerance should be placed on a lactose-restricted diet. Gluten has been shown to alter intestinal barrier function in patients with IBS-D, but the evidence supporting gluten avoidance in patients with IBS is conflicting. Soluble fibers are recommended for patients with IBS. The role of food allergy in IBS is unclear. Given a potential benefit in terms of IBS symptoms and the overall health benefits of exercise, physical activity should be recommended in patients with IBS. Patients with moderate to severe irritable bowel syndrome symptoms that impair quality of life are recommended treatment with pharmacological agents. Polyethylene glycol is recommended for constipated IBS-C patients who have failed soluble fiber trials. Patients with persistent constipation despite treatment with PG are recommended treatment with lubiprostone, linaclotide, or plecanatide. In patients with diarrhea-dominant symptoms, antidiarrheals are recommended as initial treatment and bile acid sequestrants as second-line therapy. Alocitron is approved for the treatment of severe diarrhea-predominant IBS in female patients whose symptoms persist for 6 months and have not responded to all other conventional treatments. It is not approved for men. It may have rare but important side effects. In patients with abdominal pain due to IBS, we use antispasmodics as needed. In IBS patients with constipation, we start antispasmodics only if abdominal pain persists despite constipation treatment. It is recommended to try antidepressants in patients whose abdominal pain persists despite antispasmodics. Antibiotics should not be routinely recommended in all patients with IBS, but in moderate to severe IBS patients without constipation, a 2-week trial of rifaximin is recommended, especially in patients who have bloating and have not responded to other treatments. Unlike adults, there is limited evidence to support the use of antidepressants in children. Probiotics are not routinely recommended in patients with IBS. Although they have been associated with improvement in symptoms, the magnitude of benefit and the most effective species and strain are unclear.